Thank you all for dedicating your time in delivering those thought-provoking presentations. And also, our thanks goes to chairpersons, Professor Dulani Gunasekara and Dr. Nalin Gamatike for their kind presence. It is now time for the first plenary, and I would like to cordially invite Dr. Harsha Attepattu, Consultant Obstetrician and Gynecologist, Desaisa Hospital for Women, and Secretary of Sri Lanka College of Obstetricians and Gynecologists, to chair this session.
Thank you very much. First of all, may I thank the Perinatal Society of the Sri Lanka for inviting me to chair this session, where the talk will be given by my good friend, Tiran. Professor Tiran Das, MBBS, MD, MRCOG, is a professor in fetal medicine and a senior lecturer in obstetrics in University of Kelaniya. Professor Das has held and holding several positions in academic and scientific bodies. He is a member of Royal College of Obstetricians and Gynecologists, a member of International Society of Ultrasound in Obstetrics and Gynecology, a member of Sri Lanka College of Obstetricians and Gynecologists, and a member of Kandy Society of Medicine, Sri Lanka. Professor Dias is a past secretary of Perinatal Society of Sri Lanka. He is also the editor, Gallo and Imna Clinical Society, and was the chief editor for Sri Lanka Journal of Obstetricians and Gynecologists. An expert in this particular field of fetal medicine, where you consider the fetus as a patient, Tiran would be the best to deliver a speech on advances in fetal medicine. Thank you very much. Over to you, Tiran.
Good afternoon. Thank you very much, Harsha, for your kind introduction. I think this is not the best time to talk, but I'll try to make it so simple that everybody could understand. I know the audience is very different from obstetrics, but I'll try to simplify everything that in my topic. Now, over the period of time, the field of fetal medicine has evolved, especially during last decade. Now, new diagnostic techniques have come to our practice. Therefore, now most of our fetal problems we can diagnose very early. Therefore, now the focus nowadays in fetal medicine is to pick up problems early in pregnancy. Now, scope of my presentation, first I'm going to discuss certain disorders that we can pick up in early pregnancy, especially the chromosomal problems, the pregnancy-induced hypertension, and then the fetal growth restriction, and then abnormalities in the baby. Then during second half of the pregnancy, how we can predict early labor, preterm labor, and whether we can do any genetic tests to find out possible etiologies for fetal abnormalities. And later on, in third trimester, IUGR that I'm going to talk. Now, first trimester, it's very important we to understand the concept of screening. Now, every woman, when they become pregnant, they are at risk of getting a baby with trisomy 21. Now, at the moment in our country, we don't have a policy of trisomy 21 screening, but in other part of the world, they have trisomy 21 screening. They opt for that test between 11 and 14 weeks. The first test that they offer is combined test. They combine fetal nuchal translucency. Nuchal translucency is a very simple thing that anybody could understand. That is a fluid behind the baby's neck. And you combine that ultrasound feature with some blood tests that is there in the maternal blood. Those are placental hormones, mainly the pregnancy-associated protein A and free beta HCG. Now, when you combine those two hormones with the nuchal translucency, you can give a figure of nearly 95% certainty that whether the baby is healthy or not. Now, as you could see the image on your right, the top one is a normal nuchal translucency. The image on the right bottom is the baby with the increased nuchal translucency. Simply, baby with increased nuchal translucency at higher risk of having Down syndrome. Now, apart from Down syndrome, there are other two syndromes. Common syndromes are the trisomy 18 and trisomy 13. Those are also, we can pick it up by these tests. Now, this is how you do nuchal translucency. First important thing, you just need to take mid-sagittal view of the baby, and then now as you could see, now mid-sagittal view where the baby should be in neutral position. Then you can see the entire baby, and then you just check the fluid behind the baby's neck. Most important thing, the correct magnification, because if you don't magnify the image until you see the upper thorax and the baby's head in the screen, your measurement is going to be wrong. Now, this is the correct magnification that you need to have for nuchal translucency, upper thorax and the head. Then you can measure the nuchal translucency. Now, apart from ultrasound nuchal translucency, there are other ultrasound markers. You can look between 11 and 14 weeks gestation. You can check the baby's nasal bone, whether it's there or not. At the same time, you can check the blood flow through the ductus venosus and the blood flow through the tricuspid valve. Simply, babies with nasal bone are at lower risk of trisomy 21, whereas babies without nasal bone are at higher risk of having Down syndrome. At the same time, when the ductus venosus, the blood flow resistance is high, it indicates the possibility of a Down syndrome baby. And if there's a tricuspid valve regurgitation, that also direct towards the high risk for Down syndrome. Now, if you combine these three additional markers along with the nuchal translucency, you can increase the detection rate up to 95%, and then you can reduce the false positive rate to 2.5. Now, the combined test, the test that I have described right now, is the test that we used to do as a general screening. Recent past, we managed to identify the cell-free DNA, fetal DNA in maternal blood. Now, if you get a sample of blood from mother, it contains the DNA of baby, basically cell-free DNA, because the DNA can be outside the cell as well as inside the cell. The DNA which is outside the cell can go through the placenta and can be in the maternal circulation. Therefore, if you take sample of blood from mother, the part of it is from the mother and the rest is from the fetus. Now, you can sequence the DNA what is there in the maternal blood. From that, you can find out exactly from which chromosome that DNA fragment has come. By simply counting number of fragments that has come from chromosome number 21, and if that is out of proportionate for that particular gestation, you can predict whether this baby is having the mother is having Down syndrome baby or not. Just simply count. For example, now if baby is normal, then you are supposed to see a certain number of DNA fragments from the chromosome 21. But suppose if mother is having Down syndrome baby, the chromosome fragments from the DNA fragments from chromosome number 21 is more in maternal blood, that you can pick it up. That's the fundamental, the basis of the cell-free DNA. Now, this is the most or the latest test that we do. It's available in private sector in Sri Lanka. Now, we do a lot of these tests because the ability of cell-free DNA to pick up Down syndrome is almost 99.6%. Is very, very accurate with a very, very low false positive rate with about 0.1%. And good thing about this cell-free DNA, apart from Down syndrome, trisomy 18, trisomy 21, we can see other micro deletion like Dye-George syndrome and Cridusha, Fragile X. They have a wide range of minor chromosomal problems that we can pick it up by this test. Now, this is the newest test, but the problem is it's expensive. It costs about 250 to 350 US dollars per test. Now, if you see the overall performance of each and every test that is available so far, if you just consider maternal age, it gives you the maximum detection about 50%. But if you combine age and then the ultrasound features and biochemistry, serum biochemistry, that is PAP-A and free serum beta HCG, it will give 95%. But if you do cell-free DNA in maternal blood, it's more than 99%. Now, then from chromosomal abnormalities, then we'll move to the preeclampsia. Now, it's very important for me to understand the importance of preeclampsia. The preeclampsia is either number 1 or number 2 killer in the world at the moment. That is one of the major reasons for maternal deaths among pregnant women. Okay, therefore, it's very important if you could pick it up very early in pregnancy, and if you could do something to reduce the incidence of preeclampsia, then it has a value. That's why now the present understanding is that now we screen all low risk women at the beginning, and we can pick it up high risk women that possibly can go into preeclampsia, and we can do some intervention to prevent preeclampsia. Now, preeclampsia broadly we can divide into 2 groups. The preeclampsia before 37 weeks we call preterm preeclampsia, and then preeclampsia after 37 weeks, that is the majority, that is the term preeclampsia. Now, the basic pathophysiology is given in the flow chart. Is preeclampsia is basically due to abnormal trophoblastic invasion of the spiral arteries. Now, the recent study that was published in 2017, now if you could combine maternal mean arterial pressure along with the blood flow through the uterine artery is the main blood flow from the mother to the placenta. If you can see the uterine artery blood flow, and at the same time, if you could measure pregnancy-associated protein A and another placental protein in maternal blood that is called placental growth factor, all together, you can pick it up to 76% certainty, the people who are going into the preterm preeclampsia. But detection of late or term preeclampsia is not that accurate, but what we need to pick up is early onset preeclampsia, because early preeclampsia, that there is a thing that you can prevent. Late onset preeclampsia, anyway we are having very strict monitoring during latter part of the pregnancy, therefore we can anyway pick it up and we can manage easily. But most important thing, if you start aspirin for whom you have higher risk detected by this algorithm, 150 milligram at night before 16 weeks, and you can reduce the incidence of preterm preeclampsia by 62% and 82% reduction the preeclampsia before 34 weeks is very good number. Now, same study, secondary analysis, now they have dig into the data and they found that main reason why the outcome was not that good in the group where the outcome was not good, the compliance. If patient is very compliant, and then if you maintain compliance more than 90%, then you can achieve very high the prevention rate. Is very high prevention rate. But now we as obstetrician we used to give aspirin for chronic hypertension patients. Now it is now proven now chronic hypertensive patient is not that much effective aspirin in terms of getting preeclampsia prevention. But if you just get rid of everything, But if you maintain compliance more than 90%, and if you exclude people with chronic hypertension, you can reduce preeclampsia by 95% if you start aspirin 150 at night at correct time. And then we'll move to fetal growth restriction. Fetal growth restriction is the number one killer of the baby. Like preeclampsia is the number one killer of the mother, fetal growth restriction is the number one killer of the fetus or the baby. Now, if you could pick up babies who are at risk of the fetal growth restriction early in pregnancy, and if you could do something, either at least you can put them into a correct monitoring chart, you can prevent intrauterine death. Now, again, very recent study in 2016 by Gratakos. Again, they have combined mean arterial blood pressure, uterine artery blood flow, and another chemical from the placenta, soluble FMF like tyrosine kinase, the hormone, and placental growth factor. And they can detect early onset fetal growth restriction up to 86%. But a little bit higher false positive rate, doesn't matter. Nothing is going to lose by just having false case, but if you could prevent a death. Now, therefore, those are new trends in fetal medicine, because now, as you know, in our medical school days, we used to learn that every pregnant woman, we need to have more clinic visits during latter part of the pregnancy. Reason being, we know as a fact that most of the pregnancy complications like preeclampsia, fetal growth restriction are common during latter part of the pregnancy. But we don't know a method to pick them up early or screen them in early. Therefore, as a blanket policy, we screen everybody more frequently during latter part of the pregnancy to pick them up, though the incidence is not that much high. But if you have a screening strategy like this, to pick them up in early pregnancy and separate them off from the normal pregnant group, and then have a very tailor-made care for them and routine care for others, then you can save resources. Then, now, the anomaly scan is the routine for structural abnormality screening. Normally, we do anomaly scan around 20 weeks. Now, the present context, now, we used to screen fetal abnormalities very early in pregnancy because of the very sophisticated ultrasound, the machines that we have and the skill, we can see most of the fetal structures in a very early pregnancy. These are the structures you are supposed to examine during your early pregnancy scan: skull and brain, face, spine, heart, thorax, abdomen, and limbs. And if you see, and almost everything you can see properly, but there are some limitations. For example, if patient is obese, then you might not be able to see through a transabdominal scan. Then you might have to do transvaginal scan. And these are the detection rates for abnormalities in different studies. As you could see, when it comes towards 2010, detection rate is going to be around 70%. Now, these are certain abnormalities that you can pick up at even 9 weeks: acrania and exencephaly, and the encephalocele, the hydrocephalus. Yeah. Now, we'll talk about another important thing that all of you are very much interested about: preterm birth. Now, this is one of the challenging tasks for the neonatologist, to have a preterm baby. Now, if you get entire preterm birth before 34 weeks, 2/3 are spontaneous. That means nothing you can do, they just go into spontaneous labor. But 1/3 iatrogenic, we do delivery because of some maternal or fetal indications, like preeclampsia, fetal growth restriction. Now, out of that 2/3 of spontaneous preterm birth, that means that nothing you can do to prevent it at that onset, the majority of them are low risk. That means they don't have any previous history of preterm birth. Therefore, you don't know, they just come with labor before 34 weeks. Therefore, that's the reason why we can't reduce the incidence of preterm birth over the last 50 years. Now, recently we have found that now asymptomatic shortening of the cervix is the reason of most of these preterm labors that you can pick up at 20-week scan. In 20-week scan, if you could offer her transvaginal scan and measure cervical length, and if cervical length is less than 25 millimeters, that she is at very high risk of delivering before 34 weeks. This is how you measure cervical length transvaginally. Even your setup is not that good to measure transvaginally, then at least do transabdominal measurement. And as you could see here, the length of the cervix is inversely proportional to the risk of preterm labor. It's more among twins. Then what we can do? Now, the women with no previous preterm birth, just don't read the top two, but the women with women with no previous preterm birth, only finding, if they are only finding is short cervix at 24 weeks, or between 20 and 24 weeks, if you could apply cervical cerclage or the stitch, cervical stitch around that period, you can reduce the incidence of preterm birth by 15%. But if you use vaginal progesterone at 20 weeks and continue it till 34 weeks, you can reduce preterm labor, preterm birth by 40%. Antibiotics, the other things are not going to be that effective. But if you get a patient with previous history of preterm birth, if you put cervical cerclage or if you use vaginal progesterone, it will reduce the incidence of preterm labor by 25%, whatever method that you are going to use. But as you could remember now, right now I told you, most of them are asymptomatic women without having previous labor, the preterm labor. Therefore, majority of them are them. If you screen them and if you pick them up at 20 weeks having cervical length less than 2.5 centimeters, and if you prescribe them vaginal progesterone from 20 weeks up to 34 weeks, you can reduce the incidence of preterm labor in that particular group by up to 40%. Thereby you can reduce the number of preterm births. Then, now these are the common abnormalities we see during second trimester. Now if you see a common abnormality, always we are trying to match that abnormality with a possible underlying genetic issue or an infection. That's the first thing that we do. Because if that abnormality is associated with an abnormal genetics, then outcome is going to be very bad. Same as for an infection like toxoplasma or CMV. Now, if it is not associated with structural, the genetic problem or in an infection, then you need to assess the severity and the available facilities to do any correction after birth. Then you can counsel. Now, so far, what we did, if you see an abnormality that could direct towards possible underlying chromosomal abnormality like omphalocele, holoprosencephaly, diaphragmatic hernia, those all are associated. There's a possibility that they could associate with underlying chromosomal abnormality, trisomy 18, 13, 21, whatever. Now, we generally offer karyotyping, either amniocentesis and karyotyping or fetal blood sampling karyotyping. But still, just doing karyotyping, we can just find out whether there's a trisomy or not. But still, there's a possibility without having chromosomal, trisomy, there may be subtle genetic syndromes that you may not be able to see by conventional karyotyping. Therefore, you need to do next generation sequencing. That means you can go into detail about the DNA sequencing inside the gene inside the chromosome. This is the newest that we do now. If you see an abnormality, especially like diaphragmatic hernia, if you can't find any other abnormality, before you say the prognosis, you just do amniocentesis and you do either whole genomic sequencing or the whole exome sequencing to find out whether this could be associated with any rare genetic syndrome, because then the outcome is going to be bad. There's no point we to correct it even after birth. The new generation, the simple version of new generation sequencing is the sequence hundreds or thousands of genes, whole genome in a short period of time. But the problem with this, the whole genomic sequence, it's very, very long and very heavy database. If you ask for a whole genomic sequence, it will give the entire genome, the coding, non-coding, every possible genes. It will come as a hard disk. Then you have to go and dig and find out whether there's any abnormality. It costs about $1,250 US. It's not that informative, but for rare problems, you might have to do it, not for all. But now, smaller version of this, you can do whole exome sequence. The exome is mainly the disease-causing segment of the protein-coding segment of the DNA gene, that you can do whole exome sequencing, but it is less costly, about $350 US. It represents about less than 2% of the genome, roughly around 3 million base pairs, but it contains up to 85% of the known rare diseases. Now, this is a new thing that we do in our practice now, but expensive. In the last bit of my lecture, the late onset fetal growth restriction, because now up to, I think, this decade, we used to go to perinatal meetings in most of our hospitals, and we see intrauterine deaths, and we do postmortems, but nothing you can find. Everything is normal, but baby is dead. Now recently, we managed to find out that most of these unexplained intrauterine deaths are due to undiagnosed fetal growth restriction at term. Now, growth restriction at term is very unique thing, because when baby comes to a certain level or a certain gestation, if you just measure baby's weight is going to be normal. Therefore, if you plot that weight on a customized chart, baby is perfectly grown. But the problem is, the baby can't get enough nutrition and oxygen from the placenta from that particular point onwards. The placenta is not properly formed. Then suddenly, the metabolic issues will come and hypoxia will come, and his heart is going to develop acidosis and sudden death. At the time of death, baby is within normal range. That's why you do postmortem, structurally normal baby, size is normal, but baby is dead. Now, term fetal growth restriction, the reason. Now, late onset fetal growth restriction. In order to pick it up, now the present understanding, you need to offer a scan around 37 weeks. You do general biometric size, but size is going to be normal, but you need to do Doppler. That means the blood flow resistance of the baby's brain and the blood flow from the placenta to the baby, that is the umbilical artery, and the blood flow in the uterine artery. You have to combine all three together. Then you can see and diagnose late onset fetal growth restriction. But if you diagnose late onset fetal growth restriction, it's important you to put them in a strict monitoring chart and deliver them appropriately without going into compromise. Same thing. There's a new concept has come called cerebroplacental ratio. You get the ratio between the Doppler values of the brain and the Doppler value of the umbilical artery, and you get the ratio, and then you monitor that ratio from diagnosis, and then that's a follow-up. It's going to go, if it is going to go up and beyond the reference, at that point you need to intervene and deliver. In the summary, the first trimester screening we started with age, now it has come to an era, then you can take sample of blood from mother and look for baby's DNA in maternal blood, very non-invasive, and you can pick it up to 99% of the chromosome problems in the baby, but a little bit expensive. And you can combine maternal characteristics with some maternal bloods as well as some ultrasound features, and you can predict most of the devastating complications of the mother and the baby, like preeclampsia and fetal growth restriction. When it comes to preeclampsia, if you could start aspirin before 16 weeks, you can prevent early onset preeclampsia up to 75%. And mid-trimester assessment of cervical length is very effective method of preventing preterm birth, because most of the preterm births are among low-risk women, and therefore universal screening is mandatory to pick them who are at risk. At risk group, if you start progesterone, you can reduce preterm labor by 40%. And new generation sequential technique like WS and whole genomic sequence can pick up rare genetic disorders with babies with structural abnormalities. And universal screening for late onset fetal growth restriction at 37 weeks can prevent undiagnosed, unexplained fetal death at term. Thank you.
Thank you very much, Dhiran. Especially finishing this informative lecture within the given time period of 30 minutes. We have about 1 minute to go. Any questions? Dhiran, I have one question, because you know, in our national program, we don't have a stipulated scan offered for the pregnant women. We do scans, but there is no time interval that is really depicted and where we should do a scan. These scans are mandatory.
Yeah.
So what are the mandatory scans that you think which are important for women?
Yeah, I think now first important scan that we should offer for every pregnant women is the dating scan. It should be done between 11 and 14 weeks. Then we can do dating. Apart from dating, you can train our guys to do nuchal translucency. At the same time, you can check for Down syndrome. And the second most important scan at 20 weeks, where you can see structural deformities as well as you can screen for preterm labor. Third scan at 37 weeks for low risk women, but if somebody is high risk, anyway we are putting them in a strict growth monitoring chart.
Thank you very much. Any more questions? So in the absence of any more questions, I conclude this session. Thank you very much.
Thank you, sir, for that comprehensive presentation. It is now my pleasure to invite our chairperson, Dr. Harsha Attapattu, to present a token of appreciation to our esteemed guest speaker, Professor Tiran Dias. Thank you, sir. Next, I would like to invite Dr. Kapilani Jayasekara to present a certificate of appreciation to our chairperson, Dr. Harsha Attapattu. For our next symposium, I would like to cordially invite Dr. Mangala Disanayaka, Consultant Obstetrician and Gynecologist of Ketumati Maternity Hospital and Chairman of Scientific Activities and Research of Sri Lanka College of Obstetricians and Gynecologists. Also, Professor Guani Lianage, Professor in Pediatrics, Colombo South Teaching Hospital, to chair this session.
Good afternoon, ladies and gentlemen. So let me welcome for the Symposium 3 on preterm birth. It's my pleasure to introduce my good friend, Dr. Sanath Landrol. He's going to talk on optimizing the care in preterm delivery. So Dr. Landrol is a senior consultant obstetrician and gynecologist at Carson Street Hospital, and he's a member of RCOG and SSCOG. He is currently in the editorial board of the SSCOG as well, and he's a past president of the Menopause Society of Sri Lanka. and most importantly, he will be taking over the Perinatal Society next year. Landol, it's over to you.
Thank you, Mangala, for your very kind introduction. Good afternoon, everybody. And this is not the right time to do a lecture anyway. I think after a very heavy lunch, most people want to sleep. Anyway, those who can sleep, they can sleep, and others can listen. So I think Professor Tiran Dias has made my lecture easy because he has discussed certain things. What I am going to discuss today is the optimizing the care in preterm delivery as an obstetrician, more or less in a obstetrician perspective. So, preterm delivery or premature birth is a birth occurring before completion of 37 weeks or 259 days since the first day of the last menstrual period of the mother. Every year, the disease burden is so much, an estimated 15 million babies, that means more than 1 in 10 births, are born preterm worldwide. And this number is, mind you, it is rising. So imagine the disease burden what we are dealing with. As Professor Dias very correctly said, it is that we can't predict this. Most of the cases, 2/3 of the cases, we can't predict this. In our context, Sri Lanka, approximately 24,500 babies are born prematurely each year. Our annual birth rate is about 340 deliveries happening in Sri Lanka. Out of that, 24,500 babies are born prematurely each year. So, the preterm birth is a leading cause of neonatal mortality worldwide. It is the second leading cause of childhood mortality up to 5 years of age. So these two problems are very heavily affect on the country's economy because you have to pump huge amount of money to deal with these neonatal problems. In Sri Lanka, for the year 2016 and 2019, the neonatal mortality rate per 1,000 live births has gone up from 5.8 to 7. So still, we are not handling this problem properly and effectively. Large proportion of admissions to the intensive care units large proportion of the admissions to the neonatal intensive care units are preterm babies. Mind you, the survivors are at increased risk of lifelong disabilities. The portion of them are dying, but those who are surviving, they are at risk of lifelong disabilities, including global development delays. In addition to that, there's a negative impact on maternal mental health. Imagine having a sick baby, taking to home. It is really a psychological trauma. And not only that, it is affected to the family and it affects to the national economy as well. To maintain, to look after these babies again, it is a burden to our economy. This slide is very busy slide, but I think it is clear to the back of the hall. These are the childhood mortality up to the 5 years of age. I mentioned earlier, because of this preterm problem, those who are survived, the problems can extend up to 5 years. So you can see it. The lower respiratory infection top the list, and neonatal preterm complications, then the diarrheal diseases, neonatal asphyxia and trauma, and congenital birth defects, and so on. So out of this list, the lower respiratory infection and neonatal preterm complication are number 1 and 2 in this list. So WHO classify extremely preterm, that means less than 28 weeks of pregnancy, and very preterm 28 to 32 weeks of pregnancy, and moderate to late preterm 32 to less than 37 weeks of pregnancy. Now we look into the risk factors and predictors and outcome of preterm birth. Quite sad to say, there are unmodifiable risk factors. This include short cervix, less than 25 millimeter, before 28 weeks, and history of preterm delivery. In the previous speaker mentioned about these things, and these are the two risk factors that are unmodifiable. Next come to age at pregnancy, pregnancy spacing, multiple pregnancies, infections, underlying maternal chronic medical conditions, level of maternal nutrition and lifestyle, maternal psychological health, and genetics are also recognized as contributors. Then later, due to the advancement of science, we are facing the problems of assisted reproductive technologies. Very sadly say, we are seeing a lot of bad outcome of this at Casa Street. We are getting a lot of twins and multiple pregnancies because we don't have an act to control these assisted reproductive technologies presently in Sri Lanka. But as a SLCOG, we have drafted this act that is called HURGA Act, Human Reproductive Act, and so we have tabled it in the parliament, but unfortunately it is getting delayed of approved by the cabinet. So once it's approved, there will be a legal number of, you can't have many number of oocytes, then there will be an act and that will be legally regularized. Not each and everybody can involve in these ART techniques. It is only those who have license by the ministry can involve in that. And the other side of that is the parents also get the protection because now at present there is nobody to look after, there is no price regulation, and there are a lot of difficulties faced by the parents. So assisted reproductive techniques also play a huge role in this preterm births. There is not a single combined screening method for preterm birth with high sensitivity at present. That is a bit of a negative mark in it. Now we will move into factors associated with preterm labor. These are the factors that are associated with preterm labor. Multiple pregnancies, as I mentioned earlier, this as a result of fertility treatment. Then the uterine distension, again polyhydramnios and multiple pregnancies. Previous history of previous preterm labor, maternal stress, then the decidual hemorrhages, previous mid-trimester miscarriages, and ascending infections, and smoking. That is also a rising factor in Sri Lanka now. And earlier we didn't see a lot of smoking pregnant moms, but now urbanly we are seeing. So these are the factors associated with preterm labor. How do you evaluate patient with preterm labor? This is very much important for the PG trainees as well as other doctors who are keen interest on reducing the burden of preterm birth. Initial assessment of women with preterm contractions to find out the likelihood of patient delivering prematurely. The diagnosis of PPROM is made by observing the pooling of amniotic fluid by sterile speculum examination. So you have to do a sterile speculum examination and you will see pooling of lico with the speculum examination. If the pooling is not observed, the NICE guideline, latest one 2020 advice, performing a Phosphoryl insulin-like growth factor binding protein 1 test, PIGFBP1. And unfortunately, these tests are locally not available. Or placental alpha macroglobulin 1 test, PAMG1. Both these tests are not available, so we are helpless in that way. Unless we see it, we will miss it. So diagnosis of preterm labor for women with intact membrane should follow the clinical assessment, which include clinical history taking and sterile speculum examination. If the mother is 30 weeks or more, the likelihood of birth within 48 hours is determined with transvaginal ultrasound measurement of cervical length or fetal fibronectin test. The second one, fetal fibronectin test, is not available locally. Diagnosis of preterm labor, the NICE guideline 2019 mentioned the diagnosis is there are 4 stages. There should be symptoms, and then you have to offer clinical assessment. History and speculum examination should be done. Symptoms of preterm labor, these are the low abdominal pain, show, but without examination. Then if you suspected preterm labor, there should be symptoms. Speculum examination or digital vaginal examination suggestive of preterm labor, and that is suspected preterm labor. Diagnosed preterm labor, there should be suspected preterm labor with positive diagnostic test, that is transvaginal scan or fetal fibronectin. Then the last one is established preterm labor. If it is established labor, there should be a cervical dilatation more than 4 centimeter with regular uterine contraction. This fourth one is quite dangerous because then mother will deliver prematurely. Further to diagnosis of preterm labor, if suspected preterm labor and less than 30 weeks, your management should be based as preterm labor. Then if you are suspected preterm labor and the fetus is more than 30 weeks, you have to do transvaginal scan to assess likelihood of delivering within 48 hours. When you are doing the transvaginal scan, if cervical length is more than 15 millimeter, unlikely preterm labor, then you can counsel the mother and discharge. If the cervical length is less than 15 millimeter, then you have to diagnose preterm labor. Such mothers should not be discharged and they should be admitted and kept in. Suppose if you don't have a transvaginal scan, then there's a very simple test, fetal fibronectin, but it is not available, as I mentioned earlier, to assess the likelihood of delivering within 48 hours. The PG trainee should know this FFN, and if positive, that means 50 nanogram per ml, then it is a diagnostic of preterm labor. If negative, that means less than 50 nanograms, then you can counsel and discharge that kind of patient, and they are not suggestive of preterm labor. If transvaginal scan and FFN both are not available, then you have to manage as a preterm labor because you don't have any way to diagnose them. That kind of patient you can't discharge. You have to manage them as preterm labor. The important thing is don't use both tests in combination. The one test is enough. Either transvaginal scan or fetal fibronectin. Don't use both in combination. If history of PPROM, then you have to offer the speculum examination. Examine for the pooling of amniotic fluid. If pooling present, diagnosis is confirmed, no further tests needed. You have to manage that patient as PPROM. If no pooling, then offer IGF-1 or PAM1, I mentioned earlier, in the vaginal fluid. If IGF binding protein 1 and placental alpha microglobulin 1, PAM1, if positive, do not diagnose as preterm labor straightly, consider clinical symptoms too, and previous history of preterm labor, and then you have to manage accordingly. But if it is negative, you are quite certain that that is not the PPROM. But these two tests are not available at present. Don't use nitrelacine test to diagnose PPROM. According to the NICE guideline 2019, they don't recommend nitrelacine test. Do not perform diagnostic test for PPROM if labor become established in a women reporting symptoms suggestive of PPROM. If the cervix is dilated 4 centimeter and if she is getting the regular uterine contraction, then no point of going for diagnosing, then you have to manage that kind of babies. Management of preterm labor. Management of preterm labor begins with the comprehensive history, examination and investigations collaboratively aimed at determining the diagnosis and excluding the feto-maternal complication that require imminent delivery. This is the most important part which is missed by our postgraduate trainees, because they give very little attention to get a full history, which is history and examination and investigation. So I always tell my trainees, you have to get the history before you diagnose it, and you have to examine. Treatment modalities for the management of preterm labor include, I am not going to detail, it is the antenatal corticosteroid therapy, and which has a huge impact on the preterm baby's management. Then rescue cervical cerclage, you can always put a rescue cervical cerclage, and there are cervical pessaries, progesterone pessaries, then the tocolytics, antibiotics, administration of magnesium sulfate, and fetal monitoring. All these things you have enough tools to involve in the management of preterm labor. Most of these things are available in Sri Lanka, and you can incorporate these things in your management. Then I will, in 2 to 3 slides, I will discuss about the prevention of preterm birth. Now, so far I have discussed the diagnosis and the management. So how do we prevent this? Prevention starts pre-conception care. You have to promote family planning to minimize teenage pregnancies. As you are aware, the teenage pregnancies, they are more prone to get preterm labor. And better inter-pregnancy intervals. So by family planning is not a method to stop growth of population. It is not racial. It is not a method to stop growth of population in any human being. It is the method of spacing only. And then lifestyle modification, especially the women who smoke, they should stop smoking. And then eating healthy food and micronutrient, supplementation, and optimization of pre-pregnancy weight. These are very much important, and you have to include, if a question is asked about in your MD part 2, you have to include this, otherwise you are missing big chunk of your answer. Then the antenatal care is education of the mother regarding early warning signs, the possible complication of pregnancy, which I mentioned earlier, and the healthy behavior, and the necessity of regular antenatal clinic visits are very much important. In the meantime, we have to advise them reducing multiple pregnancies. Now, in my practice, there are a lot of women comes. can we get twins? They are more interested to get twins than a singleton pregnancy, because they don't know the risk of multiple pregnancies, and they ask in drugs to have 2 babies at a one go and finish it up. That kind of attitude is there. Then reducing maternal infections, as I mentioned earlier, and you have to optimize treatment of medical disorders, those who are already diabetic, those who are epileptic, those who are having thyroid diseases, all of them, you have to optimize their treatment and get them conceived. Cervical length screening and cerclage. Earlier I mentioned about the rescue cerclage, and this is therapeutic cerclage, and you can apply a cervical cerclage in advance. Then progesterone prophylaxis, quite effective, and there are cervical pessaries are there, that's also quite effective. Prevention of preterm labor, as NICE 2019 guideline, you have to offer a choice of prophylactic vaginal progesterone or prophylactic cervical cerclage if both are present, a history of spontaneous preterm birth or mid-trimester loss, or else results from transvaginal cervical length of 25 millimeter or less between 16 and 24 weeks of gestation. Then there is a place for prophylactic vaginal progesterone in either a history of spontaneous preterm birth up to 34 weeks or mid-trimester loss from 16 weeks onward, or results from transvaginal cervical length of 25 millimeter or less between 16 weeks and 24 weeks. When using vaginal progesterone, start treatment between 16 weeks and 24 weeks of pregnancy and continue until at least 34 weeks. Consider prophylactic cervical cerclage, result of a transvaginal cervical length of 25 millimeter or less between 16 weeks and 24 weeks. With past history of PPROM or cervical trauma, it is recommended to put a prophylactic cervical cerclage. So, my time is reaching the end. So, I think the preterm birth, preterm deliveries are both a problem to obstetrician as well as the neonatologists. This is the problem of both ends. So, we have to tackle that very carefully, and you should be updated because these data are updated quite often. So, you can't live in the past, you have to update your knowledge and please manage your preterms. Thank you.
Thank you, Lenrol, for enlightening us on an important subject for obstetrics and pediatrics as well. So I think we have a few minutes spare. Can I take any questions? So in the absence of any questions, I'll ask my co-chair, Gwani Alinage, to introduce the next speaker.
I'm pleased to invite the next speaker. He's a special guest speaker from United Kingdom, Dr. Amit Gupte. He's the lead for neonatal critical care services, John Radcliffe Hospital, Oxford, and the lead for international medical doctors, Oxford. It was a great contribution for our budding neonatologists. And he is also the honorary senior lecturer at the University of Oxford. And most importantly, he was instrumental in establishing the neonatal transport system in Sri Lanka, and that won the BMJ South Asian Award in 2017. And he is going to share with us his 11 years of experience at the neonatal intensive care unit at John Radcliffe Hospital, and also his research into effects of preterm birth on lung growth and development. With that, I would like to invite Dr. Gupte for his presentation.
Unfortunately, I'm traveling, so this session cannot be a live Zoom link, and I'm sending you a pre-recorded talk. The topic that I have been given is related to challenges in managing preterm babies, which is pretty much the entirety of my job that I do in Oxford. and I would be unable to do it justice because it's such a wide topic, but I would like to focus on one or two aspects of the challenges in the allocated time. Suppose we should begin with understanding the burden of preterm birth. It is now the leading cause of child death. Of the 7.6 million children who die before their fifth birthday, roughly 40% of these deaths now occur in the first month of life. So there's no doubt we have a big challenge on our hands. It comes as no surprise that the highest rate of preterm births exists in sub-Saharan Africa, and some areas have a preterm birth rate of more than 15%. The biggest number of preterm births come from Asia, India and China contributing to a large extent. And of course, the top 10 countries listed here contribute to more than 60% of the world's preterm birth population. So it's a substantial, again, no surprise that babies who are born in low-income countries and in medium income countries, these babies form the chunk of all the babies of the 15 million born per year. And one of the worrying characteristics is that the rate of preterm birth is actually increasing. Survival is improved, no doubt. If you look at data from the UK published in 2018, the main area where survival is poor is in the 22-23 weeks, 24-25 weeks, and the 26-27 weeks. There too, in the top category, you can see that more than 80% of the babies survive. So survival per se is not a very big issue once you cross 31 weeks of gestation. You're closing and reaching approximately 100%. The challenge for many of the places in Europe and in America is the group which is between 22 weeks and 28 weeks gestation. The graph, this is just the graph which is expanded. The challenge is there, the rate of survival is increasing, and data from Oxford also suggests that the real challenge in survival is in the 22 to 25 weeks gestation age, and where the rates are about 50%, and intact survival is about 38%. So the larger gestation, which is 31 weeks and plus, is no longer a big challenge in terms of survival, but it's got challenges in terms of management of morbidity. The same applies for severity of disease. So this is a slide just simply shows you the severity of bronchopulmonary dysplasia, and clearly it is gestation linked. You can see the mild bronchopulmonary dysplasia rises as the gestation improves, and the severe ones fall, that's the red line, as the gestation improves. So virtually every metric in a preterm baby's life is related to gestation. Not just in the short term, but in the long term as well. This is a study which was just published in the BMJ in 2020, and we can see the ones which are marked in purple, these are the very tiny preterm babies born less than 28 weeks, and we can see that over the period of first 7 to 10 years, the hospital admission rates is highest in this group. It starts coming down as the gestation approaches term. So preterm birth is if you're born very preterm, not only you've got excessive neonatal morbidity, but your problems continue to exist after discharge, and there is an increased risk of hospital admission. So a framework to look at the challenges for preterm birth could be gestation, as we discussed. Late preterm babies, which are 34 weeks and above, form 83% of the chunk, and the main problems with them relate to feeding, respiratory distress, infection. If you go down the gestation 28 to 34 weeks, they form approximately 10% of a neonatal unit's population, and the main challenge there tends to be respiratory distress, infection, and NEC, tends to rear its head, but it's still the incidence is very low. It is less than 3%, I would imagine, at that gestation. In the extreme preterm population, which is less than 28 weeks, every morbidity rises. So you can look at the lungs or IVH or NEC, everything goes up. One, one way to look at challenges of preterm birth is the age of the baby. Most of the challenges lie in the first 72 hours as the baby is making a transition from fetal to neonatal life. And most of the IVH, 70 to 90% of the IVH happens to take place in the first 72 hours. PDA becomes prominent in this at this time and becomes a challenge later on. You've got the lungs, which are particularly vulnerable and have got dynamic changes in compliance, both during transition at birth, but also due to surfactant therapy, and they are particularly vulnerable to injury. So the first 72 hours is a particularly challenging period, and I think a lot of attention over the last few years has been focused on this. The later neonatal period is the next phase where lungs do form a problem, but then you've got other issues that take hold, such as NEC, sepsis, and nutrition. And the long term effects are, of course, there. There's a lecture on it soon after this one, which I won't cover. But one other challenge of preterm birth is to look through the prism of cost. I just wanted to make a point that the cost of human resources is about 70% of your bill. Now that is the same, literally that proportion, irrespective of where you are around the world. So it doesn't matter whether you're in Asia or in the UK. Human personnel cost a lot of money. Now that also puts into perspective the capital costs that you have in management of preterm babies. I think they are obviously huge, but they tend to be one-off. What you really have recurring is the cost of human personnel. So I just wanted to give you a perspective that if you want to see challenges of preterm birth, you can see it in these sort of categories. Now, I obviously don't have time to cover every problem that exists after birth. The first 72 hours, which is the transition, has been covered by Dr. Sanat Landrol. So that takes away a huge chunk of what I was going to say in the beginning. Of course, respiratory care, where my interests lie, becomes a challenge both in the first 72 hours of life, but also later on. And of course, the long-term aspects are going to be covered by Dr. Nishani Lucas. So I'm going to focus on the respiratory challenges because I think they are one of the biggest challenges that we face in newborn care units, and my time allows me to give you a glimpse of what we should be doing with respiratory care. I would like to take you through some of the guidelines that have been recently published, and these are a very good way to explore this issue. NICE published some guidelines in 2018. So the question they were asking is, what respiratory support, excluding resuscitation, because that's been covered separately, is the most effective for preterm babies before admission to the neonatal unit? This primarily includes avoiding ventilation per se. So we'll talk a little bit about CPAP versus ventilation, CPAP versus surfactant, and this is just to avoid ventilation. The next big question we've got is, what is the most effective way of using surfactant in managing respiratory distress syndrome? It is about the dose of surfactant, the type of surfactant, but also the way you give surfactant, whether you give surfactant via a non-invasive technique such as mist or laser, or whether you use insure, or whether you use surfactant by intubating and ventilating babies. What is the effectiveness and safety of the different types of assisted ventilation techniques in preterm babies? And here we've got non-invasive techniques such as high flow, and CPAP, but also out of the invasive techniques, volume and high frequency oscillation. So I hope to give you a broad synopsis of the current data which relates to the effectiveness of these therapies. It's important to understand what outcomes are we looking for when we talk about respiratory care. BPD, lung injury, as you can say, or chronic lung disease, that's one of the key outcomes. How damaged are your lungs, or how safe can you keep your lungs using various therapies? Death, of course, is an important factor, but neurodevelopmental outcomes are increasingly important. Interestingly, a large chunk of the respiratory data, including ventilation, including non-invasive or surfactant or non-surfactant, does not have a lot to do, does not report a lot in neurodevelopmental outcomes. Number of days of ventilators, that does matter, I think. Parental satisfaction, yes. And of course, economic analysis is important. So this is the broad parameters. But the challenge we face, of course, is this. The rate of bronchopulmonary dysplasia, which is oxygen dependency at 36 weeks, below the 25th week of gestation, has virtually remained unchanged over the last 15 years. We have just looked at our data last year, and the number fluctuates anywhere between 68 and 75%. So it just tells you that the preterm baby, which is less than 25 weeks, continues to be a very big challenge. The ones between 26 and 28 weeks are less of an issue. That's where the debate is on how much of non-invasive support you should be giving. And I think that's the bigger chunk of babies you are looking after in Sri Lanka. Right. Avoiding ventilation at birth, as we say, golden hour or the golden few days. What should you be doing? Now, lots of studies have been done. CPAP at birth versus intubation. We had the COIN study and support. These were all done 8 to 10 years ago. CPAP at birth versus intubation plus surfactant, ensure the CPAP, 3 arms, CPAP, surfactant plus CPAP and ventilation. So what we know is there is a combination of various modalities which include CPAP and or surfactant or intubation. The sum total is that if you look at most of the major trials that were done, especially in the very vulnerable 25 to 28 weeks, that gestation period, you can see that the long-term outcomes, both death and BPD, or death alone or BPD alone, all that favors CPAP. It's interesting that you've got this very strong piece of evidence, but we need to look at this evidence in a bit more detail. And we know that 33 to 83% of the infants who form part of this group, which are very preterm, do get intubated at some point. So the question is, which babies benefit from avoiding ventilation at birth? Virtually all of them should, but you have to understand that if you've got a rate of 83 to 90% of babies getting intubated in the first 24, 72 hours, you've got to begin to question yourself whether they should have been intubated earlier or from the start. Now that of course remains a challenge. Our own data from Oxford would suggest that virtually all the babies in 22 to 23 week gestation got intubated in the first 24 hours. So the evidence does point to benefit from avoiding ventilation. The question is, at what gestation do we pin this very strongly? Now, there are benefits, as to summarize. The evidence mostly relates to babies which are 26 weeks and above. For this group, I think, and these are the babies you're looking after in Sri Lanka the most, CPAP should be the first line of recommended treatment. For less than 24 weeks, the failure rate of CPAP rises, and we've got to ask ourselves at what point do we think that we should not try it. It is still up for challenge. The Committee on NICE actually did say that CPAP would not be suitable for preterm babies born very early. Probably not, less than 25 weeks, because these babies may not have the necessary respiratory drive, and because the failure rate of non-invasive ventilation is very high. So for these very babies, very tiny ones, you might be fair, you might actually feel that it is a lot more practical to use invasive ventilation with surfactant in delivery room, because you've got to balance the risk versus the benefit. Having a baby on non-invasive ventilation and then going through physiological strain before intubating the baby may not be the best thing for the baby. The evidence isn't there, but this is simply to suggest that the evidence for benefit typically lies in the much more mature preterm baby and not the 23-24 weekers. Right, the next question is, which is the most effective way of using surfactant in managing preterm respiratory distress? You've got various ways you can give surfactant. We in Oxford have started using LISA quite a lot, and MIST or LISA, these are very similar. You can also use Ensure, but of course the standard therapy remains as intubation and ventilation. Now, LISA is something that we've begun to use the last 2-3 years. It is something that needs training. It is simple, but it needs training, and it is not that LISA is available throughout the UK. The number of units using LISA is increasing, but it does take time. What does the evidence tell us? Minimally invasive techniques such as MIST LISA versus Ensure or conventional ventilation, if you compare the two, the trials which have been recently done include 4 large trials which either compare Ensure with conventional ventilation, intubation, or MIST versus all endotracheal intubation, MIST versus Ensure, or MIST versus CMV. The evidence seems to point out that if you do use minimally invasive surfactant therapy, it actually is better for you in terms of reducing bronchopulmonary dysplasia. And the diamond, as you can see, is firmly planted on the side of the minimally invasive therapy. So I think if you are going to avoid mechanical ventilation and you will try, if you're on CPAP and the baby is failing CPAP, if you have to give, when I say CPAP, I mean CPAP or high flow, and if you have to give surfactant, the question is, what should you be doing? You should preferably be using MIST. What dose you should be using, 100 versus 200. Actually, the NICE committee did not make a firm recommendation. We use 200 milligram per kilo as a first dose, and then if the baby requires a repeat dose, then it comes to 100 milligram per kilo. So the committee also mentions that in babies that do not require invasive ventilation, that minimally invasive surfactant administration was the best. But it also mentioned that if you don't have trained people, then you should be using Ensure as an alternative. So that's important. Next, if you want to give non-invasive support, which is the best? Now, Oxford is slightly biased because we've been using high flow since, I would say, the past 15 years or so. So we've got a lot of experience that we've built up over the years. For us, if there is a baby who needs non-invasive support, we put all those babies on high flow. In fact, our use of CPAP is virtually, it is very limited. It is CPAP is being increasingly used in Oxford in extreme preterm babies who are less than 25 weeks, as we feel that the evidence towards the use of supporting the use of high flow in the very tiny gestation is actually not very strong. Yes, the evidence seems to be favoring CPAP. I think more evidence will get collected, but many units have chosen to use CPAP as a default, and it's perfectly fine to do that. Default method of supporting babies non-invasively. However, um, we feel that our experience in using high flow puts us in a position, and data that we've got puts us in a position uh, of um, of still using CPAP, still using high flow to quite a large extent. Interestingly, if you ask parents which would they prefer, there is no doubt. Most parental satisfaction questionnaires would point that would suggest that high flow is preferable, and it's not surprising. Babies can feed on high flow very easily. They can make facial contact with parents. It is developmentally easier, but also it does not damage the lungs, right? So I think the jury's out there in terms of using high flow versus CPAP, but um, I can certainly recommend that in babies over 28 weeks, you should try and use high flow as much as possible. What sort of ventilation should you be using? Well, I think um, volume targeted ventilation is definitely better than pressure targeted ventilation. Synchronized is much better than non synchronized. And I don't want to go into the evidence for this because the evidence pool is very strong, and it's been very strong for the past many years, that volume targeted ventilation actually reduces the combined outcomes of death or BPD. It cuts the number of days on the ventilator by about 2.5. It has got better control of CO2. It is also suggesting that it may improve the rates of IVH, um, and virtually none of the parameters have actually improved under pressure targeted mode. So volume targeted modes is here to stay, and I think more units should be using it. A lot of people ask me this question whether high frequency oscillation as a default mechanism should be used versus volume targeted. The evidence clearly says that there is no difference. So you could use either. We use volume targeted as a default mode when we have to ventilate babies. The question then is, so this is broadly a snapshot of what the evidence is in terms of supporting the baby's lungs early in the life or later in life. What about nitric oxide? I know there's a lecture on nitric oxide which has taken place, but nitric oxide should not be used. It's not actually recommended for preterm babies. Now, do we use nitric oxide? Yes, we do use nitric oxide in preterm babies, but in those babies where we've got a back against the wall, that we've got nothing to lose, the baby is going to die of hypoxia, and we throw in nitric oxide to see whether the pulmonary hypertension component of it can be controlled. Um, Strong evidence doesn't exist, but anecdotally, people have started using nitric oxide in preterm babies. I cannot say hand on heart this is the right thing, but faced in a clinical situation where you've got nothing else to offer, many times you have resorted to using nitric oxide. In some babies, such as who have got pulmonary hypoplasia, it can be recommended for using. So overall, I would say that we should be avoiding ventilation, but we should be careful for the less than 26 weekers, use minimally invasive surfactant delivery systems, but use Ensure if it's not available. The high flow versus CPAP is a difficult controversy. We do use high flow in Oxford, and we should ventilate using volume targeted ventilation. So this virtually brings me to an end of the synopsis that I wanted to share with you. The challenges in preterm birth are many, as we have seen. I focused on only one part of it because I could not do justice to NEC or IVH of many of the myriad aspects of newborn care. And I hope that I've covered some aspect of the challenge. And I feel as a neonatologist, but also with an interest in respiratory disorders, that managing the lungs is one of the key challenges that we face in managing the very preterm babies. In summary, the challenges of preterm babies are essentially moving towards a low gestation period. I'm not for a moment suggesting that 34 weekers don't have challenges, but in terms of survival outcomes and long-term morbidities, the key focus area is less than 28 weeks for us. I think Sri Lanka will move in that direction in a few years as you've got more and more survival for the very tiny ones. But thank you for listening, and I'm sorry that I was unable to join you in Sri Lanka, but I hope to be in Sri Lanka once COVID stops and we are free to travel. Thank you very much.
Thank you, Dr. Amit Gupte, for that presentation that gave a glimpse of all the practical aspect of respiratory care of preterm respiratory problem management. I think I would leave all the questions to end of the next presentation. And I would introduce the next speaker. It's on long-term consequences of preterms by Dr. Nishani Lucas. Dr. Lucas is a senior lecturer of Faculty of Medical Medicine, University of Colombo, and a consultant neonatologist